morning, everyone. Fellow academics and the staff of University of Malaya, we are delighted today to present to you a small lecture from Dr. Lim Yi Ting of Biomedical Imaging of Department. I would like to introduce some words of Dr. Yi Ting. She's a radiologist and medical lecturer of the Faculty of Medicine from Biomedical Imaging. She completed her Masters of Radiology from University of Malaya in 2020 and subsequently served at Hospital Cebu for 2 years. She was our alumni for Masters of Radiology, and in December of 2022, she joined University of Malaya as a lecturer. She has a special interest in clinical diagnostic of gynecological imaging as well as head of neck. And she has graduated from medical school of the Penang Medical College of RCSI. Without waiting any more time, I would like to introduce to you the title of the lecture today by Dr. Yi Ting, which is Imaging in Head Trauma. Dr. Yi Ting, the floor is all yours. Thank you very much.
Thank you, Prof. Kartini, for the introduction. So let me share the screen first. Okay, so good morning, everyone. Today I'm going to talk about the topic on imaging in head injury. I will start with the clinical indication for the imaging, then followed by the types of the traumatic intracranial hemorrhage, the brain herniation, and also a little bit of the blunt cerebral vascular injury, and some of the types of the common skull fractures, and as well as the pearl and pitfall of the imaging in traumatic head injury. So a traumatic head injury means is a blunt or penetrating injury to the head due to external force with temporary or permanent impairment in the brain functions. It is the leading cause of death in the younger people under age group of 15 and 34 years old. It's mainly due to motor vehicle accident and also assault. So it can be classified as primary cause or secondary cause. So for primary is usually due to the trauma itself and caused by the mechanical force. So it can cause the skull fracture, injury to the skull, intracranial hematoma, diffuse axonal injury, and also vascular injury. So for secondary lesions is actually due to the indirect insult of the trauma, is usually caused by the primary trauma itself and typically evolve over times to hours and even days. So it can cause hypoxia, ischemia, encephalopathy, cerebral infarctions, and also it can cause diffuse cerebral edema and also brain herniation. So what is the goals of the imaging in traumatic head injury is first, we want to identify any injury that require urgent neurosurgical management. We want to look for any presence of intracranial hematoma and want to see whether there is a brain herniation due to the raised intracranial pressure. And we want to see whether there is any cerebral edema and also vascular injury. So non-contrast head CT is a primary diagnostic study for acute head trauma that we use. So it's usually we combine with the cervical spine CT, especially in a high impact mechanism of accident, because both the brain injury and also the cervical spine injury very often happen together. And sometimes we repeat the CT scan to look for subtle contusion or even intracranial hemorrhage as well. We also do a CT scan in the patient with GCS less than or equal to 13 or with a deteriorating neurological. And we also scan the patient with unequal pupils and also lateralizing weakness. So this is the algorithm that shows for the selection of the adult with a head injury for plain CT scan. And this is actually according to the clinical practice guideline in Malaysia. And this is the algorithm that we use for the selection of the pediatric patient with head injury for head CT, which is adapted by the NICE guideline that used in UK. So for CT angiography, we also do in the traumatic head injuries situations to detect any blunt cerebral vascular injury, which is 2 to 3% of the severely injured patients and 80% of the patients with defined clinical or imaging risk factor. And this I will explain a little bit more further in the later slide. And it is very important to detect the blunt cerebral vascular injury because we want to initiate the anticoagulation early to prevent stroke in this kind of patient. So for MRI, it is generally not indicated in our acute trauma setting because of the limited availability in emergency. It has a long imaging time due to patient motion sensitivity, or even some of the patient will have MRI incompatible hardware. So however, it is more sensitive than the CT for certain situations, for example, like traumatic axonal injury and also the contusion. It is also helpful in a non-accidental trauma in infant cases. So first, how do we approach a head injury in a CT brain plane? So first, we want to look for any brain asymmetrical, and then we want to determine if the bleed is inside the brain, which is what we call intraaxial, or outside the brain, which is what we call extraaxial. Then we look at the sulcus as well, the brain silver fissure, the system to exclude any subarynoid hemorrhage. Then we also change the window to look for some of the subtle subdural collection. And of course, we must look at the bone window to look for any fracture. So first, I will start with the extraaxial fluid collections. So it includes the extradural hematoma, subdural hematoma, subarynoid, and also intraventricular hemorrhage. So extradural hemorrhage is the most common of all cranial trauma cases which require the prompt treatment. It's located between the dura and also the skull, we can see here. And usually the patient will have a lucid interval in 40% of the extradural cases. It is due to the laceration of the middle meningeal artery or dural vein. So it can cross the midline here, but it does not cross the suture line, and it almost always associated with the skull fracture. So in this plain CT scan, as you can see, of a patient post. Sorry for the technical error, so I will just repeat myself and I restart at the slide of the extraaxial fluid collection, which is the type of intracranial hemorrhage. So for extraaxial fluid collections, it includes extradural hematoma, subdural hematoma, subarynoid hemorrhage, and also intraventricular hemorrhage here. So for extradural hemorrhage, it is the most urgent of all cranial trauma cases which require prompt treatment. Is located between the dura and also the skull, and most of the patient has a lucid interval in 40% of the cases. It is due to the laceration of the middle meningeal artery or dural veins. It can cross the midline, but it does not cross the suture line, and is almost always associated with the skull fracture. So in this image, as we can see that there is a hyperdense. This is an image that taken of in a patient post-fall. So we can see that there is a hyperdense lesions in the right cerebral, which is in the biconvex, or what we call a lentiform shape. So this is actually a extradural hemorrhage, and of course it caused a midline shift to the right side to the left side as well, and we can see there is a scalp hematoma on the right scalp as well. So in bone window, we can see that there is a comminuted depressed right parietal fracture as well in this bone window. So now move on to the subdural hemorrhage. It's occurred between the inner layer of the dura and also the arynoid. So it's due to the rupture of the cortical bridging vein. So it's different from extradural hemorrhage. It can cross the suture, but it does not cross the midline because of the dural reflections here. So in a plain CT brain, it can appear as a hyperdense if it is a hyperacute or chronic blood component, isodense if it is a subacute blood component, and also hyperdense if it's in the acute setting. So in this image, in the upper two, you can see that there is a subdural collections, which is in crescentric shape here in the left cerebral. And this we can see there's a hypertense and also some hypodense CT seen in here. And these subdural collections is actually causing a midline shift to the right side. And there is a dilatation of the right lateral ventricle. So because of the hyperdensity, that means that it indicates an acute subdural collection, and the hypodensity seen inside the collection is probably due to the hyperacute blood component. So other than that, we also can see that there is a subdural bleed that can extend along the interhemispheric fissure or tentorial cerebellar as shown here, and this is best seen in a coronal view. So in this image, you can see the difference between the extradural hematoma and subdural hematoma. So extra hematoma is on the right side here. You can see that it looks like a lemon shape. And for subdural hematoma, it looks like a banana shape shown here. So for subarynoid hemorrhage, it's an acute bleeding under the arynoid. So And usually for subarachnoid hemorrhage, we look into the cistern and the silver fissure in the CT brain, and is usually associated with other brain injury. Most common is the brain contusion. So if the patient has an isolated subarachnoid hemorrhage in a trauma patient, then we might want to think about other possibility cause subarachnoid hemorrhage, such as a ruptured aneurysm or any rupture AVM. And subarachnoid hemorrhage, of course, can lead to communicating hydrocephalus. So in these three images on the top, you can see there is a linear hypodensity in the right silver fissure here. And then there is also same linear hypodensity in the right parietal, and this is indicate of the subarachnoid hemorrhage. And of course, on the soft tissue window here, we can see that there is also a occipital subclavian collection. So this is a typical of a contra Cook injury of the brain. So for intraventricular hemorrhage, it is uncommon and is carried a poor prognosis. It is the sequence of severe trauma usually occur from reflux of subarachnoid hemorrhage or extension of an intracerebral hemorrhage. So we can see in this image, there is a hyperdensity here inside the right lateral ventricle, and this is intraventricular hemorrhage. And of course, we can see other types of hemorrhage. We can see there is a right subdural hematoma, and we got a left subarachnoid hemorrhage in the silver fissure, and there's a small hyperdens in the right frontal, and this is a brain contusion. So now move on to the intra-axial injury that includes of contusions or intraparenchymal hematoma. And we have diffuse axonal injury, brainstem injury, and also post-traumatic cerebral infarction. So now we start with the cerebral contusion first. So it's also called brain bruises. It's usually located at the near skull in the area of the Cook and contra Cook area, most commonly in frontal basal and also anterior in the temporal lobes. So CT findings may show normal in the early stage, and small or occult contusions may only become apparent on follow-up imaging due to further hemorrhage or surrounding edema. So this is an image of a patient in a severe road traffic accident, which is taken at the day of the injury. We can see that there is a small hyperdensity in the left frontal region, and this indicates that there is a contusional bleed here, and there is a surrounding hypodensity, and this is surrounding edema. And other than that, the patient also has a subarachnoid bleed and also a subdural bleed in the frontal and also interhemispheric feature. So one day later, the patient repeated the CT scan, and we can see that the contusional bleed is now larger in size, and also the surrounding edema is worsened and causing a mass effect onto the left lateral ventricle. So this for diffuse axonal injury is the most severe form of traumatic brain injury due to acceleration or deceleration or even the violent rotation. So it's patient usually present with loss of consciousness at the time of the trauma, and is a frequent cause of persistent vegetative state or severe neurological impairment in the patient. So the clinical symptoms is usually worse than the imaging finding, and it can occur isolated with no or little association with subarachnoid or subdural bleed or even fracture. So 50 to 80% demonstrate a normal CT scan upon the presentation. 80% are the non-hemorrhagic cases. Small petechial hemorrhage measuring 1 to 50 nm, typically located at the gray white matter junction, corpus callosum, and also brainstem if it is in the more severe cases. So the number and the location of the bleed is actually bleeding predicts the prognosis, and it is worse if there is a multiple lesion and it is located in the supratentorial region. So if let's say we have an initial CT scan that is negative, then a diffuse axonal injury is highly suggested, then we need to perform a MRI for further assessment. So in MRI, susceptibility weighted imaging, or what we call a gradient echo sequences, is very sensitive to detect any susceptibility artifact or what we call a blooming artifact of a petechial hemorrhage. And for non-hemorrhagic lesion, it can be visible as hyper-intense signal on the T2 and also flare sequences. So this is a CT image that taken in a patient from a severe road traffic injury, and the patient has GCS of 5 in the ER and intubated. But in the CT scan, we only can see that there is a small hemorrhage, practical hemorrhage in the right temporal region, and also a faint hypertensity, which is subtle practical hemorrhage in the midbrain. So because there is the discrepancy between the CT finding and also the patient general condition of the GCS 5, so the patient was then followed by a MRI. So in this MRI, we can see that this is a T2 sequence and this is a flare sequence. We can see that there is T2 hyperintense thickness and also flare hyperintense signal in the right temporal, the left temporal, and also in the midbrain region as well. So in this green, the GRE sequence, we can see that there is a blooming artifact in the right temporal, frontal, and in the right parietal and corpus callosum. And all these are actually at the gray-white matter junction. So this lesion actually corresponding to the restricted diffusion on DWI and NDC. So this suggestive of a particular hemorrhages. So for brainstem injury, also we call a direct hemorrhage. That means that there is multiple small hemorrhages located in the midline of the midbrain or pons near the pontomesencephalic junction. It is due to the severe trauma and it carries a poor prognosis. Is caused by the raised supratentorial pressure and cause the transtemporal herniation of the brainstem and mesiotemporal lobe and subsequently result in the tearing of the pontine perforator and bleed in the brainstem. So in this image, we can see that there's a small bleed in the midbrain here, in the pons, and also we can see there's a bleed in the junction between the midbrain and also the pons. On the coronal view, we can see, of course, we can see a large subdural hematoma on the left side, and also we can see there is a left ankle herniation that compressing onto the underlying brainstem here. So now I will talk about the brain herniation. It is the mechanical shift of brain tissue from the normal location into the adjacent spaces as a result of mass effect. It is a life-threatening condition that requires prompt diagnosis. So I will start with the subfalcine herniation, which is the most common type of herniation, which also called midline shift. It's a shift of singular gyrus across the midline below the falx, and it can cause the thinner ipsilateral ventricle. As we can see, this is a subfalcine herniation, and the contralateral ventricle will be dilated, and this is due to the large subdural collections on the right side. And this kind of herniation can lead to anterior cerebral artery infarction. So for tonsillar herniation, that means there is an inferior displacement of the cerebellar tonsil through the foramen magnum, and it can lead to the posterior cerebral artery infarction. For ankle herniation means there is a displacement of the medial temporal lobe through the temporal notch, and it can cause the effacement of the suprasellar system, and it's cause asymmetrical inferior midbrain displacement and effacement as well. And this kind of herniation can cause the compression onto the posterior cerebral artery. So now I talk a little bit about the blunt cerebral vascular injury. It is a non-penetrating injury to the carotid or vertebral artery that may cause stroke in the trauma patient. So the sign and symptom of this kind of patient include arterial hemorrhage, cervical bruit in the patient less than 50 years old in the absence of any arteriosclerotic disease. Patient might have expanding hematoma, focal neurological deficit, or neurological deficit out of proportion to the CT finding, and as well as a cerebral infarction. So the risk factor of this kind of injury is in the patient with the Leefort 2 or 3 fracture, skull bridge fracture involving the carotid canal, diffuse axonal injury with GCS less than 6, cervical spine fracture or any subluxation, and also in the near hanging cases as well. So in this bone window CT scan, we can see that there's a multiple fracture at the pectoral segment of the right temporal bone and also the left temporal bone as well, which involve the carotid canal. And of course, we can see there's a fracture in the mastoid bone as well and the phenol. And there's a multiple air locule in the adjacent area. So that means there is a multiple fracture of the base of skull. And in the CTA, we can see that both of internal carotid artery are actually irregular in wall, and it has a small in caliber, especially on the left side, and this suggestive of a dissection of the bilateral ICE. So for scalp fractures, there's the more common types of the scalp fracture include linear fracture, depressed fracture, skull base, and also open fracture. So what are the significance of skull fracture in CT scan? It can act as a marker of the severity of the trauma and usually is associated with a variety of soft tissue injuries such as vascular injury or any extension through the cranial nerve foramina or canals with any neural damage, any underlying cerebral hemorrhagic contusion, and it can also associate with the dural tear leading to CSF leak and intracranial hypertension. So how do we differentiate scalp fracture and suture in the CT scan? So for fracture, usually it appears as a smooth or jagged edge with straight line, greater in width, and it can happen in any location. But whereas for suture, it has a serrated edge, curvilinear line, less in width, and it has a specific anatomic location. So on this image, what we can see, the occipital fracture, it is a smooth line and also with a straight appearance. So this is an occipital fracture. So in contrast, lumbar suture here is shown that there's a serrated edge and it's curvilinear. So this is indicate there's a presence of the suture. Sometimes we can find that it's quite difficult to look for any subtle skull fracture in CT, but subglacial hematoma can act as a clue. So in this case, we can see that there is a subglacial hematoma on the left side, and in the bone window, actually, we can see there's a subtle hypodent at the skull, which is indicate a fracture. So for depressed fracture, that means it's a depression that greater than 8 to 10 mm or greater than the thickness of the skull. And the brain deficit is usually related to the pressure or injury of the underlying brain. So and the patient can have pneumocephalus in the CT scan, or the patient might have a CSF leak as well. So in this bone window, there is a depressed fracture, and in the brain window, we can see that it's associated with the adjacent extradural hematoma. So for skull of base fracture is a common form of skull fracture, particularly in the setting of severe traumatic head injury. And sometimes the clinical clues can suggestive of a base of skull fracture. So if let's say the patient has CSF leak, have hemotympanum or laceration of the external auditory canal, periorbital ecchymosis in absence of any direct orbital trauma, in this kind of patient, we might want to think of there is any skull of base fracture. So in CT, there's an indirect CT sign that we want to look for is the pneumocephalus, or sometimes air fluid level or opacification of the mastoid or paranasal sinuses may indicate that there's a presence of the skull of base fracture. So in this image, we can see air fluid level in the right sphenoid sinus, and if we look carefully, we can see that there is a subtle sphenoid bone fracture. So now move on to the pearls and pitfall of the imaging in the traumatic head injury. So certain type of intracranial hemorrhage can be overlooked, especially subdural and also the subarachnoid hemorrhage. So axial images are less accurate in area parallel to the axial image plane, especially immediately adjacent to the bony surface. So additional of coronal and sagittal reformation scan can lead to a more accurate diagnosis on detecting lesion at the areas like floor of the anterior and middle cranial fossa, temporal lesion, and also vertically oriented lesions. So in this example, we can see that there is some hyperdensity, which is looked a bit more subtle on the right temporal at the right temporal cerebelli. But however, in the coronal view, we can see that there is an obvious subdural hemorrhage in the right tentorium. So in this axial view, again, we don't see any obvious intracranial hemorrhage in the middle cranial fossa. But however, in the sagittal view, we can see there's a thin subdural bleed in the middle cranial fossa. So other than that, intraventricular hemorrhage also can be easily missed on CT scan, especially if there's only tiny amount of hemorrhage in the ventricle. So in this image, it shows that there is a tiny hyperdensity dependent layering here in the occipital horn of the lateral ventricle that can be easily missed. So another cause of missed hemorrhage involves the use of inappropriate window width value. If the window is too narrow, a small subdural hemorrhage may be difficult to be detected. So the optimal values vary among scanner, but a window width of 200 and a level of 50 is a reasonable starting point. So in the coronal view at the window width of 70, we can see there's a faint hyperdensity, but in the window width of 150, we can see clearly that there's a thin subdural hematoma here. So for isolated subdural hemorrhage can be easily missed as well, as Isodense subdural hemorrhage is usually seen in the subacute bleed situations, and sometimes isodense subdural hemorrhage can be seen in the hyperacute bleed patients who are anemic with a hemoglobin less than 8. So the clue to diagnose on the CT is to look for any unilateral effacement of the cerebral sulcus, any midline shift or mass effect on the ventricle, and also occasionally contrast-enhanced CT can help in the diagnosis, which is the presence of enhancement of the dura, displacement of the carotid vein away from the skull, and cortical enhancement that help to make the hemorrhage more conspicuous. So on this CT image, there is an isodensity collection in the peripheral regions, which is very subtle, and there is a medial displacement of the bilateral gray-white matter junction. So in the post-contrast, we can see that the underlying cortex appears to be more hyperdense than the isodense collections. And another clue will be the cortical vein is actually pushed away from the skull and is adjacent to the underlying brain parenchyma. That means there is a presence of collection bilaterally. So for pseudo-subarachnoid hemorrhage, we can sometimes mimic as a true subarachnoid hemorrhage in the traumatic setting. Actually, pseudo-subarachnoid hemorrhage means that there is an increased attenuation within the basal system and also the subarachnoid space. It is actually the most common cause for the diffuse cerebral edema. So in the imaging, we can look for the symmetrical density confined to the basal system with effacement, and then we look for generalized decreased brain parenchyma attenuations, distension of superficial vein due to compression of dural venous sinuses. So other causes include severe meningitis or intrathecal contrast. So in this CT brain plane axial view, we can see that there's a hyperdensity in the basal meninges and also the bilateral temporal cerebri, and this suggestive of a pseudo-subarachnoid. And another clue of this is there is a generalized hypoattenuation of the brain parenchyma, effacement of the basal system, and also generalized effacement of all the cerebral sulcus. And this is indicate that this is pseudo-subarachnoid hemorrhage in the diffuse cerebral edema patient. And this CT image is actually taken in a patient of 35 years old with a post-event of cardiac arrest. So the clinical scenario is very helpful to come to a correct diagnosis. Patient with pseudo-subarachnoid hemorrhage often has a history of anoxic events such as cardiac arrest, and the rare causes of meningitis will also have supporting clinical signs and symptoms as well. So in conclusion, when we assess the CT brain, we look from the outside to the inside, we look at the skull injury, we look at the skull fracture, primary lesions in the intracranial such as hemorrhage and also vascular injury. For secondary lesions, we look for cerebral edema, infarct or herniation. And also from the CT brain plane, we look for whether the patient need for any further imaging such as CT cervical spine to look for any injury, CTA for vascular injury, or even MRI for diffuse axonal injury. Okay, thank you for your attention.
Sorry. Thank you very much, Dr. Lim, for the very comprehensive refresher lecture. We have 2 questions for you to respond. One from Dr. Emily. Can isolated intraventricular hemorrhage occur in trauma setting? And number 2 is, how would you differentiate pseudo-subarachnoid hemorrhage and subarachnoid hemorrhage on imaging? Thank you so much, Dr. Lim.
Okay, so for the first question, whether isolated intraventricular hemorrhage can happen, the answer is yes, it can, but it's very rare because it's usually happen associated with other types of intracranial hemorrhage. And if the patient have intraventricular hemorrhage in a trauma setting, then we might need to think of other causes. Maybe we want to look for any rupture aneurysm, or any rupture vascular malform, or even look for any tumor bleed in the intraventricle, or even find out to whether the patient has a coagulopathy situations. And for the second question, if I'm not mistaken, is it to look for
to differentiate
differentiation?
pseudo-subarachnoid and subarachnoid hemorrhage.
Okay, yeah. So in these two situations, it can look quite similar, especially both also present with hypertensity in the basis in the cystern's region. So what we can see is first, usually the pseudo subarachnoid hemorrhage is less dense with the HU of maybe 30 to 40. But for true subarachnoid, is more hyperdense with the HUs of 40. But of course, for pseudo subarachnoid bleed, we want to look for any clue of the cerebral edema, such as whether there's effacement of the basal cistern, any hypoattenuation brain parenchyma, effacement of the brain sulcus that indicate that this is rather a brain cerebral edema than the true subarachnoid bleed. And of course, the clinical scenario, as mentioned, is very important to give us a clue whether this is just a purely pseudo subarachnoid hemorrhage.
Thank you very much for the reply and responses, Dr. Lim.
Yeah, thank you.
I think that's about the only two questions that we have this morning. I think I shall end this session. Thank you very much, Dr. Lim. And thank you everyone for listening in. I hope that had been a very useful refresher for everyone. And I would like to pass on the floor to Prof. Dr. Shasila for the next session. Thank you very much.